Hi everyone, welcome to today's lecture. Today we will be discussing dysfunctional uterine bleeding. Commonly, it is abbreviated as DUB. So, this is an important topic in gynecology, and we will cover its clinical features, investigations, and management accordingly. So, first, we'll slide into today's first thing, definition. So, definition DUB, it is an abnormal uterine bleeding in absence of pelvic pathology, pregnancy, or systemic disease. So, clinically, we like DUB refers to an abnormal uterine bleeding in the absence of pregnancy, pelvic pathology, or systemic illness. And it is very common in reproductive age women and can significantly affect the quality of life. So today we'll mostly focus on its causes, clinical presentation and management in both the OPD and IPD basis. And talking about DUB, like as we have discussed the definition, we define DUB as the abnormal bleeding from the uterus. So that is not explained by any structural abnormalities like fibroids or polyps, pregnancy complications, or systemic disorders like thyroid or coagulation disorder. It is essentially a diagnosis of exclusion. So this is what the definition and intro about DUB. DUB, it is an abnormal uterine bleeding in absence of pelvic pathology, pregnancy, or systemic disease. Okay, so this is the definition. Moving on to the epidemiology. So DUB is or dysfunctional uterine bleeding is one of the most common reasons women seek gynecological care. So it is most frequently seen between the ages of 20 to 40 years. The prevalence varies globally depending on the health access, but in general, up to 30% of women of reproductive age may experience it at some point of their lifetime. So it is commonly seen in reproductive age and the age from 20 to 40 years of age of women, and the prevalence will be varies. So this is the epidemiology of a DUB. Moving on to the classification. So palm coin we'll tell. So structural and there is non-structural. So structural, like when we are talking about the palm coin, the palm coin is the FIGO classification, FIGO classification, which uses the palm coin, which help us categorize the causes. So PALM refers to a structural causes and polyp, adenomyosis, leiomyoma, malignancy, etc. And the non-structural, that is the coin, that is the non-structural, refers to non-structural causes, which is coagulopathy, ovulatory dysfunctions, endometrial, iatrogenic, and not yet classified. So this is the framework of classification of DUB, which will help us to guide our investigation and management. So this is the basic classification of that is palm coin. Palm means the natural, the structural, which refers to the structural classification and for structural causes, and a coin is refers to the non-structural causes. So this is the classification of DUB. You can see in the picture below there. Moving on to the etiology. So etiology, most of the times hormonal, most DOB cases are due to hormonal imbalance, particularly in anovulatory cycles where there is no proper luteal phase. So that is one of the most important common cause of DOB, and other causes which includes bleeding disorders like von Willebrand disease, and sometimes medications such as anticoagulants or hormonal therapy can also contribute to the etiology of DUB. So here the most common cause is due to the hormone imbalance, because there will be an ovulatory cycle. So due to that there can be it can lead to the dysfunctional uterine bleeding, and other causes like maybe because of the any coagulopathies and medications, especially anticoagulants and all, or hormonal therapy. So this is the etiology of what we can say dysfunctional uterine bleeding. Moving on to the clinical presentation. So, clinical presentation, patient usually who's having a DUB present with heavy menstrual bleeding, or sometimes the bleeding which will be lasting more than 7 days. So it is a heavy prolonged bleeding, or with bleeding between cycles, so intermenstrual bleeding. So there can happen both the case. Maybe sometimes heavy bleeding which can sometimes last more than 7 days, and other is intermenstrual bleeding. In between 1 month only there can be maybe 2 times bleeding, with the bleeding between the cycles. So this is the one clinical presentation. Second is chronic bleeding, which can lead to fatigue, pallor, and even symptomatic anemia. So this is the chronic bleeding. So some patients may also, there are few patients they also may complain of dizziness or excessive intolerance and all. So that is also few clinical presentation you can see in the patient who's having dysfunctional uterine bleeding. So for two things you have to see in the, there will be heavy bleeding or prolonged bleeding, or any intermenstrual in between the cycle bleeding. That is the first thing. And second thing is, in chronic cases there can be fatigue, pallor, anemia, and dizziness and exercise intolerance also. So that is the clinical presentation. Now talking about the history taking. So before moving on to the management of the condition, we have to take the proper history of the patient. A detailed history is very essential. We have to ask the patient about their cycle regularity, their menstrual history, duration, and the volume of bleeding and all. Regarding the menstrual history, you have to ask these. Then gynecological history. Gynecological history, which includes if there is any prior surgeries or any infections and all, you can ask that in the gynecological history. Then comes to the obstetric history. In this, it which includes pregnancies, miscarriages, or any complications, and and these things in the obstetric history. And the last one is medications and systemic illness. So medication history is also very important to identify the drugs that may affect the coagulation or hormones. So medication history is also very important. Next comes the systemic illness, like you can ask for the thyroid disorders or thyroid disease, or any bleeding disorders. That is also must be assessed. So fourth thing is very important while taking history. First one is menstrual history. You have to ask about their cycle regularity, duration, volume of the bleeding. Second is gynecological history, which includes any prior surgeries or infection. Obstetric history, which includes pregnancies, miscarriages, complications. Then comes medications, ask for any drugs that affect the coagulation of hormones. Last one is systemic illness. That is, you can ask for thyroid disorders or any other disorders which the patient is having, or any bleeding disorders. That is also should be assessed. So these are the important points you have to keep in mind while taking the history of the patient who is having DUB. Moving on to the physical examinations. So in physical examination, on examination, in the general examination, you have to check for pallor and vitals to assess the hemodynamic stability. Then comes to the abdominal and pelvic examination. So abdominal examination may reveal any masses, and pelvic examination helps to rule out any structural causes which can lead to DIB. And also look for signs of systemic disease, like any thyroid enlargement or like bruising and all, anything like that. So these things you have to do under the physical examination. One is general examination, check for pallor, with vitals and all, monitor the vitals. Next is the abdominal and pelvic examination to reveal any masses or any structural causes. Last one is look for signs of systemic disease, like thyroid enlargement or any bruising in the body or anywhere. So this is the physical examination. First we have discussed the history taking. Next is the physical examination. So what under the physical examination, what and all you have to check. Then comes the investigations. Investigations, like you have to start with the CBC to assess any anemia, and coagulation profile. So like if it is very important, coagulation profile, if bleeding is heavy, then coagulation profile is also important. Then for check for the HB count. Next is the hormonal test, like thyroid stimulating hormone TSH, which includes a free T3, free T4. You can do prolactin and FSH LH. So this also can be done. This is the hormonal test you have to do for investigations. Next comes the imaging techniques like ultrasounds, which will helps to identify any structural lesions, and hysteroscopy may be indicated if the imaging is inconclusive. So if you are not able to conclude in the ultrasound techniques, then you can go for a hysteroscopy. If indeed only if it is indicated, you can go for, otherwise you can do only the ultrasound technique. So these are the important investigations you have to do to the patient who is diagnosed with a DUB to comes to a diagnosis of the condition. Moving on to the differential diagnosis. So differential diagnosis is very crucial because there are many things which may which will not be able to differentiate. So you have to make sure that you know this differential diagnosis is very crucial. First thing is structural lesions like fibroids and polyps, which can mimic a DUB. So in fibroids and polyps also, there can be a few clinical features of DUB and which can mimic the exact cause of DUB. That is the two thing. Next is endometrial hyperplasia. So that is also should be ruled out, especially in the women over the 35 years of age or with any of the risk factors which we have discussed before. That is the endometrial hyperplasia is the another differential diagnosis. Next comes the coagulopathies. Coagulopathies like von Willebrand disease may also present as a DUB. So these are the differential diagnosis: fibroids, polyps, endometrial hyperplasia, and coagulopathies. Next, moving on to the OPD management. So OPD management, here we'll see most of the patients can be managed in the OPD basis only. So the mild cases to mild to moderate cases, you can do the management in OPD. And hormonal therapy. So hormonal therapies you can do such as combined oral contraceptive pills or progesterone, which helps to regulate the cycles. Next, you can go tranexamic acid, which reduces bleeding, and NSAIDs, which will help with pain and flow. And also you can give iron supplementation is necessary if if the patient is having anemic or iron deficiency, anemia and all, you can give an iron supplementation. So this is the way you can manage the condition in the OPD basis. To mild to moderate cases, you can treat or manage the OPD basis itself. Only when if it is chronic or severe cases with acute bleeding and all, you can go for IPD management. So severe or acute cases, it requires IPD management. First thing, you have to stabilize the patient with IV fluids and transfusions, blood transfusion. That is the first priority you have to do. Then you can go for hormonal therapy, which can be given parenterally, IV or IM. If bleeding persists despite the medical therapy, then you can go for surgical options. Like DNC, hysteroscopy intervention. So hysteroscopic removal may be required. So if the patient is not getting any progress in the medical management of medications or anything, hormonal therapy and all, if bleeding is even persists despite the medical therapy, then surgical intervention is very important to like either DNC or hysteroscopic intervention. Moving on to the follow-up and counseling. So how we have to follow up the patient and counseling. Patients should maintain a menstrual diary to track the cycle. So while the follow-up of the patient, you have to always advise the patient to have or to maintain the menstrual diary to track cycles. Then next thing you can do is lifestyle modification, like stress reduction and weight management may help. And if the patient is anemic, or if it is if the patient is iron deficient anemia or any kind of anemia, so I have to address anemia, and anemia should be treated and monitored until corrected. So this is the follow-up and counseling we have to do to the patient. Next is the complications. So moving on to the complications, Complications, as I have mentioned, which involves in case of severe anemia, it requires transfusions and potential infertility if cycles remain anovulatory. So infertility also can is one of the complication if it is in chronic stage. Then quality of life impact. So there can be a significant impact on the quality of life, which including fatigue and missed work, and so there will be no enough motivation to do daily chores and all. So that is so these are the complications of DUB, that is severe anemia, infertility in chronic cases, and quality of the life impact. So this is the complications. The next comes to the summary. So to summarize today's lecture, DUB is common condition. It is a common condition, mostly benign. So mostly benign in the sense, like it can, but can affect the daily life. That is one of the important thing here. Early diagnosis is very important, and proper OPD management is also the key. So early recognition and appropriate OPD management can prevent any complications, and hospitalization is required or reserved for severe cases for or those not responding to any medical therapy. So IPD intervention is also required for severe cases. So uh, that is the important point here. First thing is the definition which we have discussed before, and the etiology and epidemiology of the DUB, and the prevalence and clinical features, and how we have to manage in OPD versus the IPD management, and also the follow up and counseling of the patient. That is also as important as the medical management. So this is very in a brief we have summarized today about today's lecture. I hope we got a clear idea of the topic, DUB, dysfunctional uterine bleeding. And that's it for today. And it's very important to differentiate it. So differential diagnosis, whichever I have mentioned, you have to keep in mind, because those things can mimic the DUB condition. So that is also very important. So let's wind up today's session. Thank you so much and have a nice day.